Thanks so much, David, for a very kind introduction and reminding everyone how old we all are. And welcome to the next part of my farewell tour. But actually, it's my see you again soon tour, as David had implied. No, don't know where, don't know when, but we'll definitely see you again. But to your point, I'm definitely still playing, and we've got a lot more to do in the coming 45 days, 44 days, whatever it is, and a lot in play, and really excited about it. So let me give a quick pulse check. How many people know that we dropped a final rule this morning? Yeah, okay, so like half. That's pretty good. So I'll talk a little bit about that. Dawn, that's why my slides were so late. I had to waiting for it to be posted on our website before I could send you the slides. And happy to talk about that in the context of everything I cover here. And I know I've got a relatively short period of time, so let me get started. One thing that I wanted to also recognize in the Sequoia project, you cover the whole expanse of, as we think about health information technology and interoperability. So for you, want to make sure that we're covering not just things like TEFCA, but what are the other things that that we do that are that you're incredibly powerful and very helpful interpreters of and contributors to. But first, just to step back for a second. If we think about where we've been, as David reminded us, I've been in this for 20 years. A lot of you have been in for more than that. But thinking about sort of the journey that we've been on, because we are on a journey and we continue to be on a journey. I think it's really important that we keep reminding ourselves of that. It started, really in like 1999, to Err is Human, Institute of Medicine, pointing out that our system doesn't perform quite as well as we'd like it to, still doesn't, and medical errors were sort of being identified by David Bates and others as being, sort of critical things that we needed to be thinking much harder about and more explicitly about. And the thought that information technology and health information technology could play a significant role in helping us to address those. Then came the High-Tech Act, and then we started our journey on the Gartner hype curve. Meaningful Use Stage 1, all of us really excited, all the physicians we were working with the Massey Health Collaborative, we had $50 million. We were helping provide organizations implement electronic health records. Everyone was so excited. I'm going to be on the beach, just not having to worry about anything because my electronic health record system is going to take care of all of it for me. Meaningful Use Stage 2, starting to get hard. Starting to feel like, wow, this is actually real work. And I'm starting to bump up against the paper-based processes that haven't changed. I've got an electronic system, but we still live in the same world that we lived in before, but now I'm actually having to force fit my electronic system into that. And then Meaningful Use Stage 3 came around, and we were seriously sliding into the trough of disillusionment. And then comes along the 21st Century Cures Act. That was a sort of an expression, I think, on the part of a number of people and obviously the Congress, but had very strong bipartisan support on both sides of the aisle for a number of things that basically recognize that we need to be doing more to get more out of this investment that we've made, $35 billion plus in public investment, at least that amount on the private side, and that doesn't include the blood, sweat, and tears of those organizations, providers, developers who are actually doing this stuff, implementing this stuff on the ground. But the recognition that we need to do more, we need to give everyone a good kick in the pants for us to be able to get interoperability and APIs and minimum data standards and all of those things that were called for in the 21st Century Cures Act. That's why 4 years ago, as I was describing this, I had and still have a tremendous amount of excitement because I feel like that's where I've been able to take this job. And it's an incredible privilege to be able to say we're now at the point where we're sort of rising to this the digital healthcare system, the plateau of productivity, as Gartner called it. And that was all before AI kind of exploded onto the scene. And you start thinking about, sort of this journey of, we've done a tremendous amount to take a healthcare delivery system, at least hospitals and ambulatory practices, and move them in a relatively short period of time for the most complex part of the most complex economy probably in the history of the world. And in roughly 10 years, move them from 10%, 5% adoption of wide variety of semi-functioning electronic health record systems to 97% of hospitals, over 80% of physician offices now using certified electronic health record systems, right? A tremendous accomplishment in moving us from a paper bricks and mortar-based world to one that we can now start thinking of ourselves as digital natives and start to think about what is it we want to be able to do if we were going to redraw the map and say we're digital natives. It's all bits and bytes. We ought to be thinking more creatively about the future. And I think that, to me, AI is the thing that will get us, to that next level. And why is that? I mean, in a way, it's, we've created this fertile ground, right? This fertile ground of bits and bytes. But I would argue, if you're going to use like an agriculture analogy, we sort of have this fertile ground, and now we have like humans with, spades and, hoes farming the land, and then we move to draft animals, draft seed drills, draft reapers, draft harvesters, all of that with draft animals. And arguably, that's a little bit of where we are today. It's still, using tools that aren't allowing us to get the kind of automation, the kind of real dynamic kind of exchange, and the ability to do much more with the information, get more signal from noise, being able to automate more, being able to bring together disparate sources of data and put that together in ways that, that generate and synergize sort of new capabilities and help us to really rethink what the value chain ought to be in a digital world as opposed to force-fitting an electronic world onto a digital world. So that's where, I would argue that with AI now, that gives us the opportunity to say, what is it that we can actually really do that makes all of this data that we've now made digital exciting, like truly exciting? Not just an HL7v2 interface, not even just a FHIR API, but what is it they're going to be able to do to be able to pull that through to say, that's why I want interoperability at the end of the day. It's not interoperability for the sake of interoperability. It's to be able to do these amazing things that I think we're just at the beginning of. So I'm going to cover 5 different areas. Apologies for those of you who saw some of this last week at the ASTP meeting. I tried to change it a little bit so to keep you on your toes. And we dropped a rule this morning to keep you on your toes as well. But I thought, again, for this audience, wanted to make sure I was covering a number of things that would be, most interesting to you, given the, sort of the nationwide leadership position the Sequoia project has played for a number of years. So let's talk first about the reorganization. The reorganization has been a topic of much conversation. It was finalized in July and reorganized parts of the Secretary's staff to consolidate resources and give accountability to the concept of technology being inherently strategic for everything that we do across the Department of Health and Human Services. It's really a recognition and a formalization of what work ONC was doing and the Secretary's staff was doing over the last 4 years, as we were seeing more and more that every single mission area, every corner of the Department of Health and Human Services was leveraging information technology, health information technology, to perform their missions. So they were using it in strategic ways to help perform their missions, and it was a recognition that we had no entity that was consolidated that had accountability at the Secretary's level to be able to help coordinate that and facilitate that so that every operating and staff division can make the best use of health information technology. And all of that discussion that was going on happened before November of 2022, before ChatGPT sort of erupted on the scene and gave specific focus to AI as one type of technology, and so that even put a further fine point on it, that we needed to be able to have that kind of accountability and sort of dedicated resources and skill sets to help coordinate across the operating and staff divisions. So we basically added another division that we call the Office of the Chief Technology Officer. We've got a Chief AI Officer, a Chief Data Officer, Chief Technology Officer. We are well on track to filling those. We have individuals named, and we will soon be able to announce the SES permanent, the career staff, career leadership, SES level, who will be filling those roles, which is a really exciting development. We felt very strongly that this needs to be something that is really instantiated with real expertise that can provide continuity and the kind of direction that, that the department as a whole is going to need going forward. And so it's really about consolidating and focusing management resources within the Secretary's office. Again, I know there's been a lot of conversation about, well, are we going to go back? Is 10 minutes left? Oh my God. I'm just getting started here. So there's a lot of conversation about this. The thing I would just say is that this is really a reorganization of the Secretary's staff. So everything we've done, we've gone through the regular processes that one would do. It's gotten clearance from every single operating and staff division, going through this, gave congressional notice, 30 days congressional notice, did a number of congressional briefings, put it in the Federal Register, all of that. And now, here we are with this reorganization that I think is getting a tremendous amount of traction and allowing the department to be able to proceed, going forward. So let's talk a little bit about information blocking. Information blocking, the steady stream of information blocking complaints continues. We get roughly, there are about, as of the end of November, 1,143 complaints, about one every business day. And that seems to be the pace that we're getting at right now. The distribution hasn't changed a whole lot. Most of the complaints are by patients about providers. Like roughly 83, over 80% on each side. Over 80% of the complaints are from patients. More than 80% of the complaints are about providers in particular, which is sort of an interesting composition that seems to be holding steady right now. And we've done a lot of work to put the pieces in place for the information blocking regulatory foundation, and that's now in place. I mean, I'm happy to say it started with the Cures Act final rule, which we put into effect in April 2021, which was the effective date now for the information blocking policies, the compliance date for all the actors, and then our partners at OIG put into effect their enforcement rule that started in September 2023. That started the enforcement part. Did not apply to providers because there were no disincentives yet defined for providers. We were able to put that into place in June 2024. So now those basic pieces are in place for enforcement, really to begin. And we've certainly started, at ONC as we think about, the things that we're hearing about in the market and starting to say, what are we going to do and how are we going to start on the enforcement path, both for provider organizations as well as for certified health IT developers. We had a number of blogs, a number of other things that we've communicated about how, how serious we take this and how we think that we have now entered a new phase where, enforcement has got to be something that we think hard about because that'll make information blocking real. And I probably have like 1 minute left, right? So let me talk a little bit about FHIR. With FHIR, I think all of you have followed us along on the journey. 2021, again, the Cures Act final rule, April 5th, 2021, went into effect. Interestingly, that was the first time that FHIR became a regulatory requirement on certified electronic health developers, which is kind of interesting that you think there was a lot of FHIR adoption before from things like the Argonaut project and Apple's picking up in the Apple Health Record that gave it a lot of industry momentum and all of the work of this community and others that was bringing it to the fore. But it wasn't until April 5th, 2021 that it actually went into regulation and that everyone was required to to implement their FHIR APIs, which happened in the end of December 2022. And then we were able to report that 97% of vendors had adopted or had been certified to their FHIR API, which again was a tremendous development going forward, gave us that baseline, which is really important. Then our HTI-2 proposed rule did a couple of things. One is, FHIR in general, we want to be able to move from interoperability to interactivity, right? How do we get to the next level of exchange where you're really thinking about systems that don't rely on my getting the data and keeping the data to myself because I'm not sure that I'll be able to count on being able to get it tomorrow, right? We want systems that are able to interact with each other in real time to be able to do the kinds of things that APIs allow you to do. The HTI-2 NPRM, the proposed rule, also has a strategic perspective buried in it, which is hard to read through the 1,000 pages of regulatory language there. But I think of it as broadening and deepening FHIR adoption. So looking at that third box there, it's about broadening adoption. It's about broadening to say, how do we think about interoperability with including payers, including public health, as well as starting to think about research and other kinds of categories. We need to break that down so that we have much more interoperability across those silos that exist in the department as well. So the proposed rule had proposed requirements related to the EHR side of the payer API requirements that our partners at CMS have put into place. Proposed voluntary certification for payer APIs that are required by the CMS regulation. And then similarly on the public health side, being able to expand it to to enable public health IT certification for those who wanted to do that on a voluntary basis. So that's kind of the broadening. And then the deepening was down in that bottom box that I know it's hard to read, was saying we need to move forward with the baseline of FHIR API capabilities to have it be more than just a read-only API that allows access to the US CDI. We need to be able to do things like CDS hooks, like subscriptions, those kinds of capabilities, which is really the goal of, of an API-based world. It's not about just a different way of making static data available. It's about being able to create dynamic systems that, that in real time can interact with each other. And then, so what are some of the things that we should be thinking about as well? I would argue, looking forward, FHIR API integration with network shared services as we think about TEFCA and facilitated FHIR. FHIR APIs communicating with each other to be able to do it under a shared services umbrella, which is what the FAST initiative, for those who are familiar with that, was all about for a number of years. That's, sort of the next step I think we need to be able to take. So that can be pure FHIR. I can say, I've got a FHIR API, I want to participate in TEFCA. I can do a patient lookup via FHIR API. I can do an endpoint lookup via FHIR API. And then I can do my query for a payload via FHIR API. Then I'll be able to do everything via FHIR, which is sort of the next step that we want to be able to do. I think there's also a number of things that we should be pushing forward on that, frankly, I think are really with the role that we see ourselves in at ASTP as speaking up for the silent majority of patients who articulate this every single day, but somehow it doesn't bubble up enough to us as an industry to take it really seriously. Things like smart health links. Why can't I just have a QR code that allows me to have a whole bunch of information that's available through that so that I can just take that from place to place, right? It seems trivial, but it really bugs patients every single day. Scheduling. Why can't I have scheduling when we've got implementation guides for that? It's really a business issue. It's not a technical issue. And then finally, imaging, the bane of every patient's existence. When someone hands them a CD-ROM and says, here it is, have fun, and you think about the opportunities with AI-enabled capabilities, why can't I get an image from somewhere and then be able to get second and third opinions from other sources with interoperability that allows me to just direct where, how access to that image ought to take place. We started down that road with HTI2, but I think that's sort of a really important thing that we need to get to. I know we've been trying for a number of years, but I think it's really important that we get there. Let's talk now about TEFCA. And as this clock isn't counting down anymore. No, oh, okay. All right, I don't want to encroach on the rest of the agenda. So TEFCA, let's talk a little bit. As all of you know, TEFCA went live just under a year ago. Actually, in 2 days, I think it'll be a year. So it's 363 days ago, which is really exciting, and it's a testament to all of the efforts of all of you and others who have contributed to this. The idea of TEFCA with the 7 QHINs that are now live, and then 3 that are sort of fast approaching designation is just a tremendous and really exciting development as we've pushed hard to sort of put together the public-private approach to this, given the direction that we've got in the 21st Century Cures Act, which was on the one hand to support network-to-network interoperability, but also had constraints that said, you're not given new authority, so you can't tell anyone that they have to participate in TEFCA, nor are you given money. You're not given budget to try to provide incentives for that. So we have to think very hard about how do we work with the private sector? How do we work with all of you to say, what is this public-private kind of partnership that can get us all to the next level? And I'm really grateful, all of us at ASTP are tremendously grateful that all of you have been able to help us forge together a, sort of a construct that actually does that allows us to use that public participation to supplement all of the private activity that has taken place to date to get us to, the next level of interoperability for some real breakthroughs. So we did, released so we've got federal agency participation as well. The Indian Health Service, as you may have seen at our annual meeting, announced that they are now the first federal agency to formally participate in TEFCA. The CDC, as you may know, has been hard at this and very, very engaged in embracing TEFCA. Over 50 public health agencies doing electronic case reporting now, and that number is growing. Social Security Administration is almost there. We've got a bunch of work that we've been doing in Social Security Administration. This is a snippet from an article that Lad Wiley and David Camp wrote, really speaking to the real value and how this is a win-win-win. People think about the $15 per record the Social Security Administration gives. That is not even close to what the real value of that is. There are patients who literally die waiting for their disability benefits. And they literally die. I had a conversation before he left with Commissioner O'Malley, and he was so exercised about having to get this done as soon as possible to prevent that from happening going forward. And the ability to relieve the uncompensated care burden on provider organizations who are still going to take care of the patients. It's just they're not getting compensated for them. Getting them linked to the disability benefits that they qualify for earlier is a huge win for provider organizations as well, for them to be able to get the compensation they need to be able to provide adequate care. And then finally the VHA, as you may have heard, Sharif Al-Nahal is very, very close as well to getting their TEFCA engagement in place as well. So a tremendous amount of federal activity, and there's a bunch just behind the scene as well. So we've got fire enablement in April. We issued a number of policies in July, and by we I really mean we. It's really a public-private partnership with a lot of collaboration, a fair degree of yelling, a fair degree of going back and forth, but all getting us there to the point where we are now. And then in November we issued a set of regulations. The set of policies focused on trust for what we're calling TEFCA required response for treatment. I'm not going to steal the thunder of the next panel, where we'll talk in greater detail about that. But a number of these things are real breakthroughs for the industry. Things like getting healthcare operations as something that's on a track and is an allowable exchange purpose. Allowing delegates who are named by principals to be able to participate on their behalf. Again, another breakthrough that allows us to be able to get certain authorized intermediaries who perform very valuable functions in the market to be able to get that kind of efficiency through TEFCA exchange. Public health, governance, I can go on, but there are a number of industry breakthroughs here that, again, we're very grateful to all of the collaboration we've gotten in helping us to move that forward. And then we dropped a rule this morning that now is confusingly called HTI-2. Why? Because it's the next one out, but it is a small part of the HTI-2 NPRM that was issued over the summer. As you can probably surmise, we've had to break up the HTI draft rule into a number of different parts. So this is one part of it. This part, the final rule, is specifically about the provisions related to TEFCA. Which is why I wanted to make sure that we were able to talk about it here. And those are, really about the federal government's commitment to providing certain sort of anchor points, as I think about it, to help to anchor the governance of TEFCA. So it's not about putting the common agreement through rulemaking. The common agreement explicitly does not go through rulemaking because we don't think that that's the right model for us to be able to do the kind of agile, on-the-fly policy making that we've found just even over the last year that we've continued to have to do. And so we very explicitly don't want the common agreement going through that kind of rulemaking, but we do think that it's beneficial for the entire TEFCA community to know that as it relates to things like designation of QHINs, as it relates to things like appeals by QHINs about issues that they may have with respect to policies and onboarding and termination, if any QHIN comes to that there is a process for them to be able to appeal and for the federal government, namely ASTP, to be able to provide some decision making on that. And so the rule is just explicit about our role in those things and how we would go about that process, which again I think is very important for anchoring TEFCA, but isn't about saying that all of TEFCA needs to be in rulemaking. All right, I'm going to skip ahead to well, let me just talk a little bit about the TEFCA updates and roadmap. So on the left-hand side, we've got statistics from the summer. Vexingly, it's hard to get up-to-date statistics. We'll work on that. But there's adoption happening. There's adoption happening, which is tremendous. And I think there's over 7-8 million records that have been exchanged over the last year, which is a drop in the bucket compared to what the nationwide networks do today and a number of the regional HIEs do today. But you have to start somewhere, and all of that is just going to have its own momentum as the tide starts rising with more and more adoption and more provider organizations and more QHINs coming online. But some of the things that that we want to be able to keep pushing on is healthcare operations. There's certainly been a bunch of angst on the payer side about where we've landed with respect to policies about payments and allowable fees and all of that. And we need to be able to break through that so that payers participate in TEFCA so that they can help to inform the policies going forward as we think about that. And we've got a number of what we're calling, well, we started calling them 10 by 10s. They're really 10 1 by 1s is probably more the way to think about it. A number of payer and providers who are very interested in moving forward with thinking about how to hash through payer and provider interoperability under a broad TEFCA umbrella. So more to come on that, but we're really excited about being able to launch those. And then individual access. I just wanted to flag a couple of things that feel like they're very important for us to be considering as we move forward. How do we make individual access real, like real? I think there are a couple of things. One is how do we implement the idea of a patient's being notified when their records are exchanged in the same way that you get a notification when your credit card is used or when something happens with your Vanguard account, for example. Someone's accessed your Vanguard account, hopefully you. And that builds trust. Right? That allows everyone to have trust when I know that I get the notification every single time. And we have the capability. I don't think it's a technical issue to be able to say that a patient who is able to connect to TEFCA ought to be able to get a notification when their record is exchanged. That will help to build trust and it'll help to create sort of more and more of a sense of why patients would want to join TEFCA, which is a little bit of a barrier right now. I think that there's more to do with respect to how do we think about individual access and how do we think about having implementers of technologies that can allow an individual to access TEFCA where that entity actually doesn't have any access to the information. Right now, the IAS flow assumes there's an organization there. So I think that's really important for technologies like the Apple Health Record, like Common Health, and others who could bring a tremendous amount of value to the table in their ability to join. And then how do we adopt a secure, portable, verifiable patient identity and governance for TEFCA-wide trust on that? I think the industry at large is fast approaching that with digital driver's licenses, digital credentials that we'll probably all start using everywhere. And so how do we intersect with that and say that that could be the model for, for TEFCA scalability of individual identity? I think there's a real opportunity for us to, think ahead and where the puck is going on that as we think about this. Okay, I better get off the stage here. So with Health AI, I won't talk too much. I'm happy to talk a little bit later about Health AI. We do have a strategic plan underway. Well, let me just mention one thing. Just January 1st, 2025, the regulations that ONC put in place in HTI 1 go into effect so that every certified electronic health record vendor is required to make available functionality about that provides transparency about the AI-enabled technologies that are in that product. It's a significant step forward, I think, and a very, in my mind, a very judicious step forward about AI-enabled technologies that allows us to complement the FDA regulatory approach, related to devices, to say, how do we move forward in a way that provides transparency to the users, provides the ability to offer safeguards, but isn't overstepping with respect to, sort of a regulatory approach for a technology area that we really don't know what we don't know. And we want to be very, cautious and prudent as we step forward in, into that regulatory domain. So that goes into effect January 1st, 2025. We're very excited to see how the EHR developers make that functionality available and how that helps to inform provider organizations as they think about their local governance and the management of AI-enabled capabilities on the ground. And the last thing I'll just mention, we are working also on a strategic plan that will be released in January that covers the entire department. We can look forward to having that be a little bit of a roadmap of where we think the department ought to be headed with respect to AI. Last point and want to thank all of you for all the support over a number of years. The ONC team, the ASTP's team, is 180 people, and I'm the only political appointee. So there's a tremendous amount of skills, a tremendous amount of enthusiasm that carries forward, with that team. So I think we should all be excited about that. And we should also just remember that we've had changes in administration, we've had changes in national coordinators, obviously, and unlike lots of other areas in healthcare and in healthcare policy, we've had pretty good continuity. Pretty good sense of the previous national coordinator handing off to the next national coordinator. And while certainly handing that rudder, there's been changes, in the rudder direction based on, the priorities of the individual, the priorities of the administration. But I don't think, we haven't seen, 180 degrees changes in the rudder. I would argue we haven't even seen 30-degree changes in the rudder. It's really been directionally following the path and building on, building on the previous work. And I think that, I have every confidence that that's going to continue with the next administration. So, and we're going to count on all of you to help that continue working with the ASTP team. So, thank you very much, and we'll see you soon.